Hello, as everybody's joining, please add your name to the chat and where you're joining us from today, and just a short description of your role, whether that's working in treatment services, peer support, research, whatever quickly captures. Great, so it looks like we've got some people from around the US, Montana, Pennsylvania, Alexandria, that might be Virginia. Some New Yorkers, Illinois, North Carolina, great. Brooklyn, close to where I am, Louisiana, Harlem, more New York City, Syracuse, spent some time there, Bronx, great. Yeah, if you didn't catch that as you were just joining, I've asked everyone to just add their name and where they're joining from today and what you do, just briefly, your role in the chat. We'll give people a few more minutes to join and then we'll get started. Great, so see lots of treatment in different capacities, some peer support, some social work, court systems, family services. So great that we have kind of a lot of different perspectives represented here. So as everyone kind of continues to add their name to the chat, great to have you here today. This is the broad theme of this workshop, which has two parts today and then the same time next Wednesday, is building bridges between harm reduction and treatment for people with substance use disorders. And we're going to kind of talk about how that title breaks down in terms of what we mean by harm reduction and broadly treatment, as well as kind of that focus on people specifically with substance use disorders, but then also kind of along the spectrum of kind of continuum of use and kind of different populations here. So just a kind of disclosure that this is the views presented here are solely the responsibility of the Northeast and Caribbean Addiction Technology Transfer Center, not necessarily the official views of SAMHSA, which does support these workshops. And I'm sure this is a topic that has come up in your work, just kind of a reminder to kind of be conscientious about language and choices in, the words we use, kind of trying to avoid stigmatizing terms, but also being patient with people as we kind of all adjust to changing practices. And, feel free to chime in if there's something you want to comment on, but kind of just as an overall rule, kind of be patient with each other. So I've already mentioned, if you haven't done so already, it's really helpful to kind of see who's here and, so add your name and broadly the role you do in the chat as you join and where you're joining us from today, what part of the country. And if you can turn on video, that's great, especially kind of when we're having more group discussions, and mute if you're not speaking. Feel free to post whatever in the chat, and you can raise your hand if you want to speak. Please just be mindful of kind of sharing the floor and being respectful of each other's views and kind of how much anyone is speaking. And there will be an evaluation at the end of the second session, so that'll be a reminder in the slides when we meet again next week. So just a little bit about me. I spent most of my career in journalism, moved to New York City just about 25 years ago now. Didn't think I'd be here this long. Also have taught media ethics, and before the pandemic, I returned to school to study public health. And since then, I've been working on projects kind of broadly to reduce overdose deaths, educate people about harm reduction, improve access to treatment, and support people in recovery. And I often collaborate with my husband, Graham McIndoe, who's a photographer who has been open about his history of addiction, incarceration, and recovery. So he spent time at Rikers Island and also in immigration detention due to charges related to, drug possession during a period of addiction, and has been drug-free for 13 years now. So this is just a couple photos of projects we've done. One is kind of an exhibition on, kind of moving beyond addiction and reframing recovery that we've done in New York City and Rochester, and are talking about taking to some other places coming up now that we're getting together again after the pandemic. And then the one on the right is a banner that's that was displayed in Brooklyn Bridge Park in New York City for a project that we did about kind of mostly interviewing people providing services and receiving services that related to reducing overdoses. So you can find out a little more about my work at my website, and there's my email, which will be repeated later. So here's sort of, I like to use a lot of visuals, being married to a photographer, so cloudy day in Brooklyn, but thinking about bridges, bridging between harm reduction and treatment as part of the continuum of care for people with substance use disorders. So, lots of talk about how things can be very siloed in this field. So, what I've really gravitated toward is kind of trying to, help kind of bolster that, sometimes refer to it as the connective tissue between, whether it's different disciplines, doing research and people providing services, or, harm reduction, treatment, and recovery support. So these are kind of the learning objections. Today, we'll really be covering the first two, which is, kind of talking about harm reduction principles, practices, and impact, and addressing questions and concerns about harm reduction and treatment for substance use disorders. And next week, we'll discuss ways to strengthen the connections between harm reduction, treatment, and other supportive services, and explore how treatment providers are incorporating harm reduction into their work. So it helps to just kind of start off. I don't know if a poll is going to pop up, but if you can just answer in the chat, how familiar are you with the concept of harm reduction as an approach to substance use? So number one would be very familiar. I could explain what it means. Number two, somewhat familiar. I've heard of harm reduction, but I'm not sure I could explain it. And not too familiar. I'm here to learn more for number three. So great. See some ones, some twos, three. In the past, some people put 1.5 or 2. Yeah, so feel free to keep adding those to the chat or any questions you have. So, for those of you who put 1, welcome you to kind of participate in the chat too and share your perspectives. And, but part of this is kind of trying to think about, how we can think more broadly about harm reduction and present it to kind of people with different levels of experience or coming at it from different perspectives. So just going to start out with a question here. So thinking about this question, particularly if you answered 1 or 2, how would you describe harm reduction to someone who asked what that means? So I'm finding myself more in a social occasion or even sometimes professionally, and I ask, have you heard of harm reduction? And, so this is thinking about what's sort of a short description that you would use to describe that. Maybe we'll start by, inviting everybody to just post an answer in the chat if that's something that you feel comfortable with. And then once we've had some time to do that, I'll also invite anyone who wants to share to raise their hand, and then, we can talk about different ways of describing that. So Lorraine, thank you. Reduce use safely until ready to abstain. Tricia says, allowing people with SUDs to decrease the severity of their use over time. So thinking about this as a gradual process. Monica, doing a risky thing in the least risky way. So we'll talk about how this isn't just an approach necessarily for substances. Kind of thinking about safety, Sharhanda. Jennifer saying an approach to keep everybody safe until they're ready to stop using. Reduce injury, decrease health issues, reduce use, and decrease health issues and injuries. Again, safety. Shauna, kind of thinking about it kind of more we'll talk a bit about this kind of being a movement, a way to view people who use substances that normalizes it and stigmatizes it. Really important points that empower individuals to begin the recovery journey in a way they choose at their own pace. Great. Lots of comments on kind of reductions, being safe, and kind of supporting people until they're ready to make changes to their use, which captures kind of the different goals that we're going to be talking about. So here kind of Brittany is getting into some specifics like needle exchange, which we'll talk about, education, really important. Yeah, overdoses, thank you for bringing that up. So I think what I'll do is kind of present a few definitions, and then anyone kind of who wants to kind of share a perspective or comment, please raise your hand and do that. Yeah, big idea of beginning to take process of kind of beginning to take control and care for their bodies again. So these, even for you, those of you who answered one, trying to bring together just the fact that there can be different ways of defining harm reduction depending on kind of the organization and perspective. So this is a very shortened version from the National Harm Reduction Coalition, and you will all get copies of the slides, and I encourage you to share them, and use the links to kind of find out more. Those will be sent at the end of next week. But this definition, describes harm reduction as a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. Harm reduction is also a movement for social justice built on belief in and respect for the rights of people who use drugs. So if you go to that page, there's a few things I kind of want to point out here that they kind of mention in a kind of longer description and context, is that, there is no universal definition. So, if you weren't sure how to answer, there's kind of not necessarily a right or wrong way. And, this idea of it can kind of distinguishing between what they point out, if you look at the top definition, that's sort of lowercase harm reduction, being the strategies, and they point out that harm reduction kind of with the uppercase HNR kind of captures the movement, whether that's something that's kind of picked up and repeated in another organization, but just kind of interesting to think about, that distinction that they're making there. And here really kind of focusing on substance use and specifically drugs. So kind of moving on here, this is a definition from SAMHSA, the Substance Use and Mental Health Services Administration, which is longer, you'll see, and kind of gets into a little bit more detail. So the way they define it on the page with the link below is harm reduction is an approach that emphasizes engaging directly with people who use drugs to prevent overdose and infectious disease transmission, improve the physical, mental, and social well-being of those served, and offer low threshold options for accessing substance use disorder treatment and other healthcare services. They also point out that it's an important part of the Biden-Harris administration's comprehensive approach to addressing substance use disorders through prevention, treatment, and recovery, where individuals who use substances set their own goals. So here there's kind of some differences, right? First of all, being a little more specific in kind of the definition of the goals considered under kind of this umbrella, and talking about physical, mental, and social well-being, as well as kind of this idea of low threshold or low barrier options for accessing services, which we'll be talking more about. And, you'll see too that a lot of government kind of discussions now kind of focus on prevention, harm reduction, treatment, and recovery, kind of these 4 pillars that are becoming more and more part of policy. And, traditionally or historically, harm reduction wasn't necessarily part of that, but is increasingly being embraced. And, really important to kind of acknowledge that people who use substances setting their own goals. So some of your definitions have talked about that, kind of empowering people and having kind of that person-centered approach. Any thoughts before I move on to one more here, or we could also open it up in a little bit here. So this is something from one of the projects I've worked on, from a young woman who's a community organizer in Detroit. And, you know, I was interviewing her and asked her about this, and her response really struck me. She grew up with two parents with substance use disorders, one who passed away from an overdose and one in long-term recovery. And she said, I think about harm reduction from the point of view of the kids helping their parents and how we can reduce harm all around. If we're thinking about healing and supporting folks, harm reduction means creating safe spaces that don't make them feel isolated or shamed. A place where it's not on the kids, the parents can get help and not be judged. Because the minute you shame them, someone else has to pick up that ball you dropped when you could have showed compassion, and it's usually the kids or family members that still come around. So that was, you know, I've been a family member, not necessarily, you know, a young child or a child experiencing this, but, you know, it just really struck me that that's an important perspective to think about when we talk about harm reduction, because sometimes when we focus on public health goals, you know, we kind of can narrow down the set of harms we're thinking about. And I thought that this was a really important way of connecting this idea that, you know, as if the system and the people and the organizations that work in providing care aren't kind of approaching people and welcoming them and treating them with dignity and respect, then, you know, what she says is, you know, it does fall on the kids and the family members. And that's an important perspective to think about when, you know, we think about, you know, harm, not just to the individual, but to their families and communities. So I like to include that just sort of as a perspective that sometimes, you know, isn't, if you're not working with that population, necessarily front of mind. Any comments or things you'd like to share from the work you do? Feel free to raise your hand or at any point, and if it doesn't pop up, or add something to the chat here. So this is what I kind of, you know, I've seen this before, just boiling it down to a simplified view. So we can have these kind of longer definitions and principles and strategies, but, you know, harm reduction, thinking about it as an approach that aims to reduce the negative consequences associated with risky behavior. So, you know, that might be a handy slide to use and present, kind of thinking about, you know, even just beyond substance use, you know, and these are kind of some examples here. You know, many of us work with substance use, but, you know, it's sometimes helpful to point out the context of how we all practice harm reduction in different ways, you know, whether it's bike helmets, motorcycle helmets, using sunscreen or a seatbelt, or condoms. You know, these are all examples of ways to reduce the potential harms of things that we do. And kind of taking this idea of kind of principles or summarizing some of the things you've shared and that's been presented, you know, just important to think about it, I think, as an approach, not a single intervention. And the idea of emphasizing respectful, non-judgmental interaction. You know, we've talked about how it's empowering people to reduce harmful behavior and supporting their goals, which might change over time, which is really important too, that none of us are static. So, you know, our goals are kind of constantly shifting depending on our circumstances. Recognizing that abstinence from all substance use may or may not be a goal. So we'll be talking more about that. And prioritizing kind of holistic person-centered care. So, you know, it's not just about the substance use, that this comes with kind of broader behaviors and challenges, and that really focusing on, you know, that person and what they need and express as their goals is really important. Any questions or thoughts? I want everybody to feel comfortable raising your hand and sharing, so don't hesitate. So some of this has come up a little bit in the chat, but just asking, you know, what are some examples of harm reduction related to substance use that you've heard about or used in your work? You know, so this is broadly, you know, any kind of substance use, so not just thinking about drugs. You know, feel free to respond in the chat. I'm seeing from Amber there is mentioned fentanyl test strips, Lorian methadone. You know, that's something that kind of sometimes be put in the category of harm reduction and treatment. Narcan, also known as naloxone, we'll talk about that. Medications that make alcohol taste bad or people have a reaction to it. So, you know, things like antabuse. Safe use Paxil, Suboxone, also known as buprenorphine, great Celeste, the Never Use Alone hotline. I'm going to talk about that. Changing your language, you know, so avoiding stigmatizing terms as a way to reduce harm. Fentanyl and xylazine test strips. Safe spaces for use, so we're going to talk more about those. Clean syringes. Great. And if I've missed anything in the chat, I'm navigating a few different windows here, but feel free, especially if you're asking a specific question, to either raise your hand or repeat it here. So, you know, thinking just even kind of broadly about substances, right? So again, kind of helpful to sometimes put things in context for people. You know, we're a few months beyond. How many of you have read about or heard about this concept of kind of dry January, getting a little more coverage in the media? I can't see everybody on the screen, but I see Maribel nodding. So, you know, that's becoming, you know, I've said in other workshops that I did that for the first time this year, and it was really interesting to me to just kind of notice my relationship and what it felt like to go to events in January and, you know, be offered alcohol and, you know, say, oh, I'm not drinking, and even kind of how that affected sort of socializing and entertaining and, you know, just, I think it's helpful for me. It was interesting to explore, you know, what that felt like, you know, even having been the partner of someone, you know, in recovery for many years, it was pretty eye-opening for me. So, you know, that can be something that's kind of under the basket of harm reduction, you know, more also low or no alcohol drinks. You know, for some people, that's an approach, you know, maybe not something every time, but, you know, kind of mixing that in and having those options available. Designating a driver, you know, that was a huge campaign, you know, as I was kind of coming up and first starting to drive, and something we all think about now and easier with sort of ride sharing services. But that's a form of reducing potential harms too. And with tobacco, you know, nicotine gum or patches and, you know, vaping kind of can be put into that category depending, you know, on the perspective and sort of what's being vaped, but all these are kind of ways of reducing harms, you know, specifically related to alcohol and tobacco. And then here are just some visuals kind of for some things that you've mentioned, you know, carrying naloxone, also known as Narcan, for the nasal spray and knowing how to use it, using new syringes and other supplies, testing drugs with fentanyl test strips, and then using with someone or calling a hotline. Never Use Alone is one example. There's some others out there. How many of you have heard of Never Use Alone? Feel free to answer in the chat. Okay, mix. Some yes, some not. Does anyone who knows about that feel comfortable kind of giving a quick explanation? If you raise your hand or if you just want to unmute, that's great. Lorraine comments, I use it for patients. Wait, I saw it. Shauna?
Oh yeah, it's just a hotline that you can call that's non-judgmental, and you call them when you're getting ready to use, and they stay with you while you use, and if you stop, if you don't answer them, if you become non-responsive anyway, then they will call authorities for your area.
Great, thank you. So there's some other options too, and I think some efforts to kind of build this into technology. And, you know, as much as kind of Never Use Alone is great advice for people, you know, there's situations where that's not necessarily possible. And there's also times, I think sometimes in some of the research I've seen, or just discussions, particularly with women, that there may be reasons why people don't feel comfortable, necessarily using in a situation where, they might feel more vulnerable for whatever reason. So, thinking about these options and kind of sharing them with the people you work with and, service recipients can kind of expand on that advice about harm reduction as, hey, if you are in this situation, they have little cards. I think you can even print them from the website and share them. And, that's just an option for people to have, particularly if they're kind of concerned about privacy or they recognize they might end up in a situation where they are by themselves. Is that the palm card someone else mentioned? I think that probably is. If anybody else knows of other services they want to add in the chat, in other workshops, I've heard about different ones that might be promoted in different parts of the country. This one is pretty national. But then, again, it's not the only option. I do have a card. That's, I think, what I took a picture of there. So just diving into kind of syringe service programs, sometimes called by different variations on that name, shorthand kind of abbreviation is SSPs, just broadly are community-based organizations that provide sterile syringes and other supplies to people who use drugs. Many of them also distribute the overdose reversal medication naloxone, often test participants for HIV and hepatitis C and help them get treatment, offer food, clothing, showers, and mail services. I'm going to talk a little bit more next week about an organization that's really built out its mail services. Often serve as drop-in centers with respite options, and increasingly have peer support and counseling available. Provide or connect participants to treatment for substance use disorders and medical care. That can be wound care, especially with xylazine increasingly in the mix. Seeing more and more development of services around wound care, and sometimes have mobile services too. So, those might be a van that goes out and parks near in a certain location. It might be a parking lot. It might be near a park. Sometimes literally people on foot distributing supplies. There's really a range of implementations of these around the country and kind of depending on the region. So, just kind of a summary of some of the evidence, when these services have been researched, and there's a couple links there that, you can follow up with later on if that's helpful. But, strong evidence showing that syringe service programs reduce HIV and hepatitis C infections, prevent overdose deaths by providing naloxone training and distribution, reduce syringe litter by offering safe disposal options. So that might be options to kind of return syringes as someone's coming to pick up other ones, or, kits sometimes, red containers or sharps disposal containers people can take away. Connecting participants to HIV, hepatitis C, and substance use disorder treatment, as well as other health services. So, that might be kind of partnering with local street medicine teams or community providers to kind of be that bridge to getting people care for something that might just be an infection, or reproductive health care and other types of care people need. And don't increase drug use or crime in the community. Any thoughts or questions? Can feel free to raise your hand or just unmute if I'm not seeing anything on screen, and comment in the chat. So this is a map that the numbers might not be totally accurate. I've had people kind of point out, who come from a different state, that they know there are many more SSPs in their state than kind of show up in this map. But, I like to have visuals, and this kind of comes from, the North American Syringe Exchange Network, and kind of a map created by the Kaiser Family Foundation, which does a lot of reporting on health around the country. And broadly, estimates vary, but I think it's fair to say there are about 500 syringe service programs in the US. If anyone has different numbers, feel free to post those in the chat. That includes a wide range of types of SSPs, and many have kind of limited hours or may only offer mobile services. And again, kind of some numbers on this map don't count all SSP locations, but you can see that it varies around the country in terms of kind of how many are there. And again, with the caveat that this might not be totally updated data. And kind of moving on to, what's called overdose prevention centers, and, sometimes referred to as safe consumption facilities or safe injection facilities. You may have heard about them with different names. So I'm trying to rearrange my screen a little bit here. But these are hygienic facilities where people can use drugs. They typically offer education, equipment, and oversight of drug consumption. And there are people there, importantly, who can intervene if someone experiences an overdose. Also provide or connect people with health and social services, including treatment. And there are about 150 OPCs in 16 countries, again, sometimes going by, other names, but most of those are outside the US, but I'm sure many of you have heard about or maybe have worked with On Point in New York City, which opened 2 OPCs in November 2021. I was about to say last fall, but been longer than that now. So one is the Washington Heights Corner Project, and one is New York Harm Reduction Educators in East Harlem. And I'm sure that many of you have seen some of the publicity about these services and have kind of know a little bit more about them. But these are 2 that are in New York City, and there are plans to, or at least approval to open one in Rhode Island. I think the goal is to get that done in 2024 to open that up. This is, if you go to On Point's website, they kind of post updated data about their, participants and utilization from time to time. So, I try to grab a screenshot of the latest data that's up there. So, since their launch, which has been roughly, I'd say, 1.5 years now, they've had over 3,000 participants and nearly 70,000 utilization. So that's the number of times people have come and used the facility, and they've intervened in close to 850 overdoses. So, one thing about these locations and On Point is that, they're really making an effort to kind of do evaluations. So NYU is their Center for Opioid Epidemiology and Policy is going to be kind of in the process of assessing the impact of On Point's OPCs on individual and neighborhood outcomes, such as non-fatal overdoses, syringe litter. So, there's really an effort to kind of engage with the community, engage with the press when they first opened, and, other parts or people in other parts of the country that are interested in finding out how this is working and, getting advice on kind of how to navigate some of the barriers. So, much of the evidence comes from abroad, but, there, again, kind of from this link, you can kind of get a link to a more robust report. But, broadly, evidence shows that overdose prevention centers reduce overdose deaths and OD-related EMS calls in the neighborhood. So, that's an important thing that, the number of times emergency services has to be called is reduced, and therefore that kind of affects, the cost of those services in that area. Reduce public drug injections and syringe litter. There had been some kind of early information shared with On Point just from the Parks Department here that, syringe litter in the area has gone down, since the OPC started operating. They do not typically increase nearby drug-related crime, serve participants who are not in contact with other health services. So I think, the fact that people do come over and over allows for that ability to create a relationship. And potentially, it may be that relationships kind of develop more than at SSPs because people are spending more time in these facilities. So that will kind of be interesting to see. and increase participants' use of health and social services, including treatment. That one is kind of tougher to pin down, and we'll kind of be talking about those linkages to care. But, broadly, that's what the research that has been done abroad shows. Any questions, comments? So these are links that, again, you'll get the slides and you can follow up on, but I think, capture different perspectives on how the supervised, here they're called injection sites, are working in New York City. So one is from a program on public radio here that, had an interview with different people, both kind of at the facility, and I think an opportunity, some other perspectives were shared during that. And a video. So, for those of you who haven't already seen a video, kind of how that's working, that YouTube video is one of the things that's been posted. And then a little kind of early research from the New York City Department of Health and Mental Hygiene, kind of on what the lessons learned so far were that came out last year. So, these are all kind of good interviews and sources for more information if you're curious or kind of want to share those. So, many of us have kind of seen that, there is growing support for harm reduction, including kind of 30 million in grants for harm reduction services that was part of the American Rescue Plan. And this is a recent article from the Washington Post kind of talking about how more states are legalizing fentanyl test strips. So in many parts of the country, those have and still continue to be illegal. So, that's another policy changing. So, and it's gradual, and, many people who've been working in harm reduction and advocating for harm reduction, would say that there's still much more to be done and kind of a lack of many of these services in a lot of areas. But, this is compared to, when some of you might have worked in agencies or places where harm reduction either couldn't be mentioned or wasn't mentioned or wasn't really embraced as an approach. So just kind of pointing out some changes have been happening, which doesn't mean that there's not resistance here. So these are kind of contrasting vetoes that came out about overdose prevention centers in California at 2 different times. I know this is a little hard to read on a shared Zoom screen here, so I'll just kind of highlight some points. So the one on the left is from 2018 when Governor Jerry Brown vetoed that. And, what it says at the bottom is fundamentally, I do not believe that enabling illegal drug use in government-sponsored injection centers with no corresponding requirement that the user undergo treatment will reduce drug addiction. So, that language of kind of enabling, something that will be familiar, I'm sure, to many of you, and this idea of, should it be required that people who use these services go to treatment in order to have them, is something that was definitely, very prevalent then and still can be today. On the right is a more recent veto from Governor Gavin Newsom when this came up last year in California. And, cites a slightly different take on the objections. And the last paragraph talks about the unlimited number of safe injection sites that this bill would authorize, facilities which could exist well into the later part of this decade, could induce a world of unintended consequences. It's possible that these sites would help improve the safety and health of our urban areas, but if done without a strong plan, they could work against this purpose. The unintended consequences in cities like Los Angeles, San Francisco, and Oakland cannot be taken lightly. Worsening drugs consumption challenges in these areas is not a risk we can take. So I imagine many of you have followed or at least heard a little bit about that coverage in California, and people can speculate what the real motivation was in terms of political ambitions. But I think this captures the fact that there are perspectives out there that anyone advocating for harm reduction or kind of develop these services kind of has to wrestle with, and and figure out, well, how can we deal with these objections? How can, we make sure that these consequences don't happen, or reassure people about, how different services can be introduced. And this is about overdose prevention centers. You can hear some same objections about syringe service programs in different places. And just to capture that, having worked in media, and I do different projects that still kind of follow media coverage. So I like to save and pay attention to how media is kind of presenting things. And by media now, that includes kind of entertainment media and social media. But here are a few examples of kind of articles that came out in the last few years. One from The Economist: America's syringe exchanges might be killing drug users. One on the top right was actually started in a local TV station in response to something someone posted on social media, going to a park where some supplies were being distributed by a local harm reduction organization in California, and filming, a young adult, well, not a young adult, a teenager who had kind of been sent specifically to try to sort of test if she could get services. So, increasingly when I'm kind of working in communities, I hear that, yes, there's problems with media coverage, but really it's social media that, for a range of things is the things that, is the source of a lot of what we have to wrestle with in terms of stigma and myths and misperceptions about not just substance use and addictions, but treatment and services, including harm reduction. And, the bottom headline is from Salt Lake City in Utah, just again, kind of capturing conflicting views in different communities. And, recognizing that it does take effort to kind of build the buy-in from the community. And I think that's something that, the On Point in New York City has tried to do before opening. Any thoughts or comments? Or sort of, you'd be curious sort of what, in the places that you're joining from, how are these services or harm reduction viewed or perceived, just kind of more broadly? And feel free to answer in the chat. Hi, Jennifer.
I guess what I'm trying to figure out, because the way I've seen it, I live in Ashburn, Virginia, and when in DC we see, but it seems like this whole system has been politicized, and I don't know like how to overcome that specifically. Like, how do you get people, like Robin said, it's stigma talking, and it really is, how do we help with that? I mean, besides our own positive talk, which can only get us so far, I just, these are very frustrating to me that it's so political when we're talking about human beings that deserve to live.
Mm-hmm. So I welcome anybody to chime in on that. And I'm going to offer some thoughts. So, first there's sort of, how do you tackle that in a one-on-one conversation, right? So partly the information here is geared toward kind of giving you some tools and resources to talk about the benefits, and whether that's organizing events within your own organization or public events, really focusing on, we live in a very polarized time, a lot of skepticism about who's an expert and evidence and expertise, but, talking about the impact that these services can have on things like emergency services, HIV and Hep C rates, engaging with a population that just is not often comfortable in traditional healthcare settings. So being able to kind of emphasize those benefits and, both in an individual level and also with the community. And then I think, part of why I included those links to some of the coverage of the PCs in New York City is that I think they did a really great job of engaging with the community and the media before they open these centers. And it's important to note that this is a service that opened within existing facilities. So it wasn't the same as the challenge of kind of getting a lease and opening in a community where you aren't already doing work. But I think that, partly learning from what's worked in other communities and how they've navigated that. But, one thing I also try to emphasize is that it's important to engage people's objections, whether you have children or navigate things with your partner, you can't just say, you know, well, this is where I'm at, you know, it's again, that meet people where they're at philosophy. If we're the people you're trying to meet are nervous or fearful, or you've heard a lot of misconceptions and myths about addiction treatment, harm reduction, you know, you kind of have to meet them where they're at and then kind of talk through some of those objections and try to be reassuring. You know, a lot of these strategies may be more effective kind of in an individual level or within an organization. You know, within a community, it gets a little more challenging, but I think organizing events where people with personal experience can speak, you know, and a lot of the work that I've done in different communities, just having an event where, you know, sometimes my husband and I are facilitating. It's an art exhibition, it's a talk on public radio, it's a presentation open to the community. But when they see, you know, and always including community members who are directly impacted with different perspectives, I think can sometimes change minds about, you know, who quote unquote these people are and what they feel they need. I hope that's, but feel free to chime in. And
I definitely appreciate that. I think that that's helpful. And I love that you said to engage even the naysayers where they are. I think that is a really great, because that's frustrating sometimes. My other question that goes with that is, do we have information like on, and this is probably too early in the game, cost savings? You talked about how it can drain on the emergency system, and it can drain on the hospitals, it can drain on different things. Are we at a point where we can estimate cost savings yet? Maybe we're not there, but that was my secondary question to that, because money always talks when you're talking to people about taxpayer dollars.
Yeah, and I think there are resources out there. One of the links that I included for the OPCs, you know, there has been some research done around that. I just saw that hand up. I don't want you to go. And, you know, as well as for SSPs, right? So the cost of, for example, Hep C treatment, it's come down, but it's still pretty high. So, you know, yes, that exists, and that's a good question. And, you know, we'll see if there's more kind of we can add in what's shared on that. Sorry, let me find Tuwana. Am I saying that right? I'm not seeing your name right now. So do you want to chime in, and then Ashley?
Yes, because I work in New York.
Okay.
And I think the information that I actually, you know, flooded the public with, and being more aware and sharing information, made it more easier for people to seek help and to have this information more tangible for them. Having the having needle exchange for the harm reduction, being located on a weekly basis on different areas that people know about, giving information. I think the education about it is more important, to let people know what's out there, so when they need it, they can have access to it. And if, as providers, having those flyers that we can share information where people become comfortable into seeking the help and seeking assistance when they need it, it won't be any prejudiceness or people feel they uncomfortable talking about it. It's more of a commonality of a discussion that can be considered as a norm, so they can feel comfortable.
Yeah, that's great. And I think, you know, we're getting better at some of these campaigns, on public education campaigns, you know, whether it's some things that are, you know, maybe on bus shelters, or, you know, in cities and subways, you know, or billboards, or having the flyers. You know, for those of you who've been around for a long time, a lot of the campaigns that we grew up with are based in fear, you know, and this is your brain on drugs kind of things. And
Yes,
you know, in some workshops I do, I ask people to kind of share, you know, well, where did you learn about addiction treatment and recovery, you know? And often the answers are about personal experience or the media we all absorb. So thinking about representations in films and books and TV shows, and now on social media, you know, there aren't places people necessarily learn about this because it's been so taboo for so long. And when my now husband was struggling, we were dating, and that was, you know, 2006-ish, at the beginning of that trajectory. And I certainly didn't feel comfortable talking about it, and specifically not heroin and crack, which were the two main substances he was using, because of so much shame. And I do feel a lot has changed about that. So it's important to kind of acknowledge progress and the fact that, you know, maybe people don't always talk about it with the most accurate information or the right language, but we are, I think, talking about it more, and the more public education can happen, can really kind of move forward. Absolutely still a long way to go, but I think, you know, those efforts are kind of happening.
Thank you.
Ashley?
So I was just gonna say to the question that was asked about the savings, I was in a training the other day on harm reduction, and there was a study out of Philadelphia that had come out, and the savings was $7 and either 53 or 58 cents per $1 that was put into harm reduction. And that was just based on the estimated savings for HIV and hepatitis C treatment.
Okay.
So the savings are pretty enormous when you're looking at the return.
Yeah, thank you for sharing that. And if you have any links that you either want to email or bring back and post in the chat next week, that would be great. I mean, there's absolutely, especially with infectious diseases, and, you know, when you think about, you know, in Indiana, for example, you know, lots of media coverage of an outbreak there when, you know, syringe service programs weren't allowed. And then, you know, I think it was then when Pence was governor, kind of coming around to changing policy on that. And I believe it's kind of shifted back. But, you know, there's a lot of data out there specifically about, you know, the savings related to not having to treat so many people for particularly HIV and Hep C. Great, thank you, Ashley. Any other questions or thoughts or things you want to share? So, you know, we've talked about this, but, you know, just on that point that, like I had mentioned, you know, engaging people's objections, and some of that comes out of kind of working in media too, you know, trying to present different perspectives, or anticipating that when you're writing a story, like, who's going to object to this and how do I address that objection? So asking you to kind of post in the chat, and then we'll share, you know, what are some concerns or hesitations you've heard about harm reduction? Not necessarily things you believe, but what's out there, what have you heard, what comes up in your work or in your communities? Enabling, yep, that's a big one. Not my backyard, another big one. Enabling them to continue to use, encourages people to use, crime will increase, rewards people, that the use of MAT or medications for addiction treatment is the same as using. Sometimes that one's, we'll talk about how that can be framed, increases use, rewards bad behavior. Kids, definitely, there can be that concern. Reduces surrounding home value, variation on kind of not near me, kind of normalizing use, that children may absorb that message is a concern. Why isn't it Narcan free, but insulin isn't? You know, so comparing to other conditions and what's available. And, you know, we live in a country with a for-profit healthcare system. So, you know, that's something that comes up here, you know, not necessarily the same challenges in other parts of the world. So some of these you've captured here. Just looking again at the chat. Okay, you know, this perspective can be out there that, you know, people might be less fearful overdose because of Narcan, that, you know, might make them more willing to try higher doses, you know, contributing to, you know, people or increasing, people experiencing homelessness. Or attracting people who have unstable housing or no housing. Yeah, so, this is kind of a summary that captures a lot of things that have been mentioned. This idea of encouraging or enabling risky drug use is a common perception. Sometimes that's framed as that it's going to encourage people to try using drugs. And really the evidence shows that that's not the case. Makes neighborhoods less safe, attracts buying and selling drugs, particularly for the OPCs. I think, bringing that activity, into a facility or a place, moves it from the street into a place where people can connect with providers and be treated with dignity and potentially access care and other services. So, seen different examples. Before I came to New York, I lived in San Francisco, and there's a lot kind of going on there, particularly in the Tenderloin area, where there is a lot more open air drug use. For a while, there was a facility that was temporarily set up that closed, partly due to kind of community objections. But, this is really kind of part of that choice is, if there isn't a place, then where else are people going? And, whose neighborhoods does that end up in? Someone's mentioning, Kensington, Pennsylvania. Sorry. Definitely a place I've spent time in Philadelphia. So spending taxpayer money on people who made bad choices, right? So this comes up a lot in the US, kind of, and really any place where you're all decisions about how money are spent are ultimately kind of policy decisions that reflect kind of different priorities, right? So if we see drug use as a choice, even if you're recognizing that, developing addictions are not a choice, people kind of come back to that argument like, well, someone made bad decisions and why should we be spending money on this? Offering medications that substitute one addiction for another. So, that's one that's specifically related to medications like Suboxone, which we'll be talking about more next week. But really this idea that, this approach is really just substituting, or MAT within this approach is really just substituting one substance for another. There can be the concern that harm reduction opposes abstinence and recovery. I've heard harm reduction advocates, say abstinence is sort of the, purest form of harm reduction. Whether that's realistic or a goal that people will choose is another matter. But, if you think about it as a continuum, then, abstinence is under that umbrella and a choice that should be supported. I've been, and I'm going to talk about a place where it's an SSP that does a lot of other services in Michigan, and their peers there are called recovery coaches, so even though it's within a very harm reduction model, they're definitely embracing this idea of recovery and promoting, any positive change as kind of a pathway that moves from harm reduction kind of through accessing services, including sometimes treatment and into recovery. Only reduces some of the harms related to substance use disorders. This is something that, I think is important to acknowledge, that particularly working in public health, sometimes public health goals kind of single out the things that impact kind of public health data gathering and public health outcomes, so thinking about, children and families and communities, and then other harms related to substance use disorders. People can feel like, well, these services that you're talking about address these harms, but not all these other harms. What about that? So I think those are important points to engage with and kind of think about and acknowledge in kind of helping change people's minds and kind of be more open-minded about things that, if you see harm reduction as kind of on that continuum of care, that, this is part of what's a broader umbrella of different services. Monica's writing, I interviewed for a harm reduction organization once, and they told me that if I have an agenda to eventually get someone into treatment, then I am not doing harm reduction. And candidly, that's something that I've heard too, sort of there can be among, I find that I hear that a little bit more in the debates that kind of happen on Twitter or, further from the people who are providing services. But, that's also something that, we're going to talk about a little more in depth kind of next week, and examples of organizations that are doing treatment, and how we can kind of think of treatment sort of in quotes much more broadly defined. That sometimes when people have objections to treatment, they're coming at that from either an outdated view of treatment or a narrow view of treatment or a bad personal experience with treatment. So, that's sort of why this workshop just talks about bridging, how do you bridge these gaps? Because it can feel like people are in different silos, and that there's not always open-mindedness about treatment the same way there's not always open-mindedness about harm reduction as an approach. So thank you. Yeah, and Robin, you're leading into sort of my next discussion. We aren't talking as much today about treatment, but we'll touch on that a little bit, and certainly more next week. This last one just here, though, I do want to point out, that sometimes people express frustration that, well, harm reduction meets people where they're at, then leaves them there. And, that there isn't, and this is really kind of getting into the heart of things we're going to talk about next week, that there can be this binary, and what can we do in that middle part between, forcing services or treatment on someone and waiting for them to be ready. I have a slide kind of talking about what's in the middle there, that's facilitating and encouraging, that these aren't kind of just two binary choices. So Robin, you've kind of introduced my next question. What are some concerns or hesitations you've heard about treatment? So I think it's fair to say that treatment, historically in the US does not have the best reputation. And within that, it's important to acknowledge the context. It wasn't covered by insurance. It was outside the healthcare system, often still is separate from mental health care, and operated in many locations and kind of on this for-profit model. And that those are the models that the media coverage focuses on a lot. I think it's important to also say that there are a lot of providers out there, nonprofit models that get less attention, that are doing work. And, again, we'll talk more next week about some of those examples of how treatment is evolving. But just inviting everyone to, again, use the chat. What have you heard as far as concerns or hesitations about treatment? It takes more than one time to work. Erica, that might be expressed as a hesitation, or just, acknowledging the reality for many people. Some are Medicaid mills. Yep, getting back to kind of problematic payment. Sylvia says treatment doesn't work, not reflecting your opinion, but hearing this exception, treatment doesn't work. I've heard that phrase over and over, that people get out and they're back to using again. And that's a frustration, that if people, if you're a family member and you're paying for this, or you're paying for it for yourself, and then, one could do a whole other workshop on bridging treatment and recovery support. Sometimes I think of treatment as sort of one slice of the pie, especially having lived through this, that, I've often said you can get the best treatment in the world, but if you don't, if you can't get a job because of a criminal record, you can't get housing because of financial barriers, or again, a criminal record, if you're having challenges regaining custody of your children, there are enormous hurdles, even for people who do receive effective treatment. So, the expectations that treatment can do everything are also something that, need to be acknowledged. Jennifer says, you know, as again, among the objections that it doesn't work, that it's expensive, that there are fraudulent companies out there. Shauna, thank you. One size fits all. And that has, you know, historically been the case. And even, you know, just thinking again about that media coverage, that what do we see if you're watching a film or a TV show? You know, there's sort of a typical, you know, for much of the time, a presentation of, oh, you have a problem, you go to a 28-day residential program, and then you attend meetings. And those things can be great, but not necessarily what everyone gets. Residential treatment is actually kind of a small portion of the treatment that's funded compared to outpatient treatment and other services. And, you know, this idea that one size fits all, both in terms of kind of the format and then the services, is something that really needs to be changed. Some can be punitive, shaming, do more damage. That's something we're going to talk about, but many people who have experienced that, and that was very much a model for many years. That kind of people feel frustrated when 12-step is sort of the only way is presented, whether that's through a formal program or other services. And thank you for sharing Smart Recovery as part of an alternative mutual aid group. There's now starting to be even some harm reduction mutual aid that, you know, is one thing coming out of the pandemic is kind of more options that people can access online. So Smart Recovery is kind of one of those. Childcare services for women, that's huge. So women face, you know, in some sense, great barriers to accessing treatment and resistance to treatment because of, you know, either fear of losing their children or the need to provide care for children. So that can be a concern or hesitation about going to treatment. Celeste writes, in our rural area, there's no immediate access to treatment. It can take days or weeks to get into inpatient, outpatient, or MAT, many barriers. I always hear if they want help, all they have to do is ask. Absolutely true, and very much the case that it depends on where you're located. And there can be this, you know, disconnect between if you have to travel well outside your community, sometimes to a different state, and then come back. You know, a model I've heard about, maybe some of you have, is kind of this idea of a healing forest. You know, if you take a sick tree and replant it somewhere else that has, you know, better soil, more rainfall, water, you know, and then you bring it back into an area that's experiencing a drought or dry land, you know, what is the expectation there? So that we need to create kind of healing communities where, you know, all the trees are getting, you know, the support, the water. Maybe I'm not doing justice to that analogy, but if you Google healing forest, you can read more. Individualized treatment should be the focus. Thank you, Albert. Monica, another great one. I just was at an event that really focused on don't do families and couples work. I mean, how many treatment programs tell you, you know, you can't call your family member, you can't reach out to them. They don't engage the family members, even though, you know, partners, family members, and again, this is family kind of broadly defined, that, you know, end up being kind of part of often getting someone to consider treatment and then helping that transition after someone has been in treatment. There's also, you know, the role of families that might have contributed to substance use that's important to address without blaming families, I think. Just going over the chat here. Yeah, this idea of shame and not being able to choose what they want without experiencing shame. Insurance barriers, approval for one type of treatment versus another. For example, have to try it outpatient before inpatient treatment. Huge insurance barriers there. So thank you for sharing those. Just kind of a slide to capture a lot of what's been shared, you know, this idea treatment doesn't work. It's difficult to evaluate success. Again, partly because how can you isolate the effect of treatment versus all the other things that's come up? Too punitive, discharging people for minor infractions or a positive drug test, not necessarily available when needed. We can have this two-tiered system based on income and insurance coverage. Reservations about offering medications for opioid use disorder or limiting access to these treatments. Some of those are starting to shift with some policy changes, but still very much exist. Too focused on abstinence as a universal goal, starting to see some movement there in terms of programs kind of recognizing, sometimes it's thinking about, a sequential approach to treatment. So, maybe someone's going to focus on their opioid use first and get stabilized. Pretty much polysubstance use being the norm now, to single out one substance and not recognize that often people are using multiple substances, can be sort of defeat some of the goals of treatment. And this idea of maybe tackling one thing at a time or reducing use as kind of a pathway to changing goals are starting to be recognized as kind of different options. And just that treatment doesn't meet individual needs, especially for certain populations, whether that's gender people, sexual orientation, race and ethnicity, socioeconomic status, geography, people have different needs for treatment, and there has been this kind of one size fits all in many places and not enough kind of opportunities for people that they can actually access and afford that kind of recognize different needs. So again, these are, broadly kind of just some concerns that are out there that are important to kind of engage with when you think about linking harm reduction and treatment. Treatment has to be something that, is appealing to people and is perceived as helpful in order to help bridge that gap. And again, kind of defining treatment broadly, I think, and we'll kind of do that a little bit more next week, but that can sometimes be narrowly viewed as a specific type of treatment, but trying to think of it more broadly as, if you're getting tested and treated for Hep C and wound care and other things, these might be part of what's considered treatment within a harm reduction setting or approach. Language barriers, absolutely. Thank you, Ada. Any other questions or comments here? Anything we missed? We will be focusing kind of more on kind of treatment next week, but just also wanted to share a few slides. Some of these statistics will be familiar to some of you. Just thinking about need and sort of people with substance use disorders. This is the national survey that's kind of often relied on. This one came out is the one that most recently came out, kind of using data from 2021. Important to kind of acknowledge, because of the pandemic, that impacted data gathering, and also how the number of people probably who register are evaluated as having SUDs. And in this case, 16.5% of people age 12 or older is what the National Survey on Drug Use and Health reports have some type of substance use disorder. And again, this isn't based on an individual diagnosis. This is a survey and how people answer survey questions. So, some people might argue that's an undercount, some might argue it's an overcount, but that's kind of broadly a number that gets used. And on the right, you can see, we hear a lot about opioids, but if you kind of look at the number of people who kind of qualify, and these may be overlapping. So someone might have alcohol use disorder and a drug use disorder, and then within that might have methamphetamine use disorder as well as a heroin use disorder. But you see this kind of goes down from alcohol and drugs to marijuana, pain relievers, methamphetamines, stimulants more broadly, cocaine, and heroin. So still, if you're working in service providing settings, no doubt you're dealing with alcohol, but sometimes that can get lost in discussions of kind of drug use disorders. And this isn't reflecting tobacco here. And, we're going to talk more about this idea of a treatment gap, but this is what came up in the survey as far as a need for substance use treatment in the past year among people age 12 or older. And what was really striking, but won't be to people who work with this population, is sort of this high percentage of people in that 18 to 25-year-old age range, and really are there the services to support that group. So this is the need for substance use treatment among people in each of these age categories. So that's saying 25% of people aged 18 to 25. That's defined as having a drug or alcohol use disorder in the past year or receiving substance use treatment at a specialty facility. So percentage is a little smaller for different age groups here. Any questions on this one? You'll get the slides again, so I know some of the details are a little harder to see here. So kind of more pointing to the treatment gap, 10% is often cited as an average number of people who receive any substance use treatment in the past year among people age 12 or older who had a drug or alcohol use disorder in the past year. So basically saying only 10% receive specialty treatment. These numbers below here for the different age group, again, impacted by the pandemic and, how services changed during that time and kind of more challenges with availability. So that's important to acknowledge too. And, the treatment gap in this figure, 10% is often cited, but not necessarily acknowledging not everyone does need specialty treatment. There are, and I'll mention this again next week, people achieve recovery without specialty treatment. It depends on what you consider treatment. That may or may not be counted in this. So, thinking about this 10% as an average, it doesn't mean that those 90% are just never going to either achieve recovery or moderate their substance use if they don't receive specialty treatment. Any thoughts on that statistic or your perspectives on that from kind of the work you do? And I think too, kind of thinking about what we visualize when we think about treatment. So, another survey came out that cataloged kind of the number of beds in residential facilities across the US. And I would have to double check this, but I believe the number was around 130,000, right? So when we think about this treatment, sometimes this idea of a residential program just really skews the perception that much of treatment is outpatient and not necessarily an inpatient or a residential program. John, you're leading into one of my next slides here. There are many out there that do not want treatment. If we tracked refusal to engage treatment instead of implying it wasn't available, it would greatly impact the statistics. And so just to go, you've previewed this next slide here. So when I first saw this and kind of started engaging with this study in graduate school, I mean, this number was quite high to me, but it's been consistent across many years. And I don't know how many of you have ever kind of come across it, but there's a lot of text on this slide, but the perceived need for substance use disorder treatment among people age 12 or older who, again, through the survey are determined to have a drug or alcohol use disorder who did not receive treatment, 97% felt they didn't need treatment, close to 97%. So, what John has pointed out here is that's a huge thing to overcome, and it probably won't be surprising to people who kind of do this work and try to engage people in treatment. And so thinking about, particularly specifically syringe service providers and harm reduction organizations that operate with extremely low budgets, like having the staff and sort of the capacity to help people get over this feeling that they don't need treatment is really a challenge. and, you know, where that comes from. If when you ask people, you know, would it matter if you phrase the question differently and said, you know, do you feel you need help? You know, do you feel you need services that would support reducing or quitting, whether it's alcohol or drug use? Would that change how people answered? Do people just have such negative feelings about specifically treatment as a word that impacts that statistics? You know, it's hard to say, but I think it would be interesting to kind of try to unpack like how you present that question and how, you know, we can talk about what people do express openness to engaging with in terms of services. Any thoughts on that? Does this, if you want to answer in the chat, does this number surprise anyone?
Hi, this is Sylvia. I'm a social worker and I work in the emergency room offering treatment services to patients who come in that have a substance use disorder. And I can't tell you how many times I've seen someone who is going through withdrawal. Their skin is pockmarked and they're beat up and their teeth are missing, and you phrase the question, would you be interested in treatment services? No, I just want my clothes. I got to go home. But, I mean, they're on their deathbed, but they refuse treatment services. So just like you said, I've been attempting to find ways to rephrase it, because there was a point where I couldn't even get them to admit that they were drinking or using. So my question now is, hi, do you drink alcohol or use substances sometimes? And when I say sometimes, they're most they're easier to respond yes, because if I just leave it blank, do you drink or use? Oh, no. Do you drink or use sometimes? And I find I get a better response. So got to tweak how we phrase it. Absolutely.
Great, thanks for sharing that. And next,
you're welcome.
We're going to talk about that idea of like, what's the best timing in place, you know, and there've been a push to have these services in emergency departments, and that makes sense. But a concern for me, or a question I would say, is that when I talk to people, many who with lived experience, many of them tell me that's the last moment because I just want to get out of there. You know, if you've been to an emergency, and that's no offense to anyone who works in that setting, but if you've been to an emergency room as a patient or with someone else, like, you know, many of us do just want to get out of there. You know, that's not a place. And I could say the same thing about, you know, sitting and visiting someone in jail or prison or other locations too. But, you know, there have started to be more experiments with kind of post-overdose response teams in different areas. So following up, and that might be a few days later. And we'll talk about some of those services next week too, that catching someone, you know, if you have their information and if there's a program in the community to do that. And I was able to watch or participate in one in a rural county in Southern Ohio and know a little bit about kind of what happens in New York City. But the timing and the place, the way the question is phrased, who asks the question, you know, peers sometimes have more success in that engagement. And then what we're kind of presenting as the option for services. So that's also part of this idea of kind of bridging harm reduction and treatment is, you know, maybe someone's going to be more interested in engaging with harm reduction services. But then once you've got that, you know, can we increase those linkages to care for other types of treatment? Monica's saying, you know, working an outpatient, so true. I feel one of the best things I can do is be pleasant, compassionate, warm, and welcoming. Even if they never come back to me, I want them to have a good experience so they are more likely to return in the future. And sometimes it's that person who isn't judging, who keeps the door open, who someone remembers. You know, I've talked to a lot of people too who say even if they started using again after getting treatment, that it's not that they didn't learn anything from that first course of treatment and they didn't build on it maybe the next time or later on. So, you know, just kind of recognizing that what someone takes away from an experience might contribute to their choices or how they experience the service after you or the next time they see you. So thinking about that kind of broadly in this context. Any other comments? Questions? I hope I caught everything in the chat today. Really appreciate what people have shared. So just want to offer a reminder, you know, we'll meet again next week at the same time. And, you know, talk about kind of a little more specifics about how harm reduction providers are offering treatment services, you know, including medications for opioid use disorder, mental health care, other basic health care, often through partnerships in their communities. And then explore how treatment providers are incorporating harm reduction practices into their work, such as not requiring abstinence from all substances in order to receive care. So again, you know, hope you can rejoin next week. You'll get all the slides at once after the second session, and there will be an evaluation, you know, but feel free to come back with, you know, anything that you want to share in the chat too, or, you know, contact us if you have questions before next Wednesday. It's Wednesday next week, so the same time, so 1 to 2:30 for those of you who are on the East Coast. Kayla had asked that, and any other questions, we'll just hang out for a little bit, but otherwise, hope you enjoy the rest of your week, and I will see you next Wednesday. Thanks for joining.